Okay, good morning everyone. Sorry about those technical difficulties. We're going to start over again for those of you who have just joined us and for those who may not have caught the actual presentation. So again, my name is Stephanie Romano, the Education Coordinator with SWORBHP, and presenting a webinar on IV access, the tips and tricks for the tricky IV in the not so tricky situation. We have Dr. Adam Dukelow, Local Medical Director, Justine, Jewell, CBRN Specialist and RN, as well as Christine Hardie, one of our regional paramedic educators. So I'll turn the presentation over to them. If you have any questions, please use the chat box, and I'll check in to make sure that you guys can hear us and see the screen as well.
Thank you, Stephanie. We're going to start with the right attitude, not the equipment. So you've done all this work and all this training, so we want you to start confidently. So don't say, I'm going to try and start your IV today. State, I will be starting your IV. If you're asked about your ability, then answer, I will do the best that anyone reasonably can. Believe in yourself and believe in your skill.
The goal of the webinar is to increase the IV cannulation success rate within the SWORBHP region. Our objectives: upon completion of the webinar, the paramedic should identify situations that may decrease the odds of a successful IV attempt, appreciate the various techniques offered to increase successful IV cannulation. Hopefully you volunteer to share your tips, tricks, and experiences that could assist others to improve their IV success rates. Demonstrate increased proficiency in pre-hospital IV initiation. And finally, we'll finish up with identifying the various components of a central venous access device and watch a short video. We'll start with a case study, which is an actual call taken from our region. The medics were dispatched to a residence, code 4, for a 61-year-old in respiratory distress. On their arrival, the patient was lethargic and not responding appropriately according to the BON on scene. The past medical history included a seizure disorder and depression. The medications are listed in front of you, and there were no known allergies. On physical exam, the medics found the patient presenting with a decreased level of consciousness. However, there were no complaints verbalized by the patient. The patient was nonverbal and not responding appropriately for himself, according to the VON. The airway was patent, breathing was spontaneous, not observed to be labored. The paramedics could not obtain a radial pulse upon palpation. The GCS, eyes were open spontaneously, localizing, and had no verbal response. This brings us to our first poll question. We're going to ask you to calculate the patient's GCS.
Okay, so you should see a poll question up on the screen now, so go ahead and take a second to read that and answer. So about 40% of you have voted, so we'll give you a few more seconds.
I suspect a few people aren't paying quite as much attention after Scrooge dumped that lump of coal in her internet experience this morning.
And just a heads up, we do have 4 more polls, so keep close by to your computer for this one. Okay, so here are the results to your poll question.
So good job, guys. The answer was 10. I mean, it's important, definitely important to be able to calculate a GCS for a number of reasons for all paramedics. It plays into your CTAS score as well as your level of concern about the patient.
On physical exam, the paramedics noted the patient's vital signs as follows. The heart rate was 140 regular, blood pressure 61 on 45, breathing at 16 breaths a minute, blood glucose level was 10.7 millimoles, and the temperature was 36.5. Remarkable physical assessments that were reported were cool extremities without a radial pulse. The stroke assessment was negative, and the medics found crackles to the left side of the patient's chest and good air entry on the right. So I'll just have Dr. Dukelow lead the discussion regarding the patient's treatment and differential diagnosis.
So all of us, whether we're physicians or nurses or paramedics or any type of healthcare provider, when we walk in the room to see a patient and we have a little bit of information or a little bit of a database we've created on that patient through our history and physical exam, might not be diagnosis, but basically present a complaint. So this patient, in my mind, is presenting with an altered LOC, as evidenced by their GCS of 10 and all the things that make up that, as well as a significant decrease in their blood pressure. There are numerous mnemonics you can use for creating a differential and making sure you don't miss anything. I think you've probably all heard of the AEIOU TIPS mnemonic. It's something that's taught in the colleges and is throughout the paramedic community. I don't think we need to go through the specifics of that acronym, because you could easily Google it and find out what they were if you haven't heard it before. But what I'd be more interested in is in people's impressions as to what this patient's most likely diagnosis is, because that will lead to what the appropriate treatment for the patient is. And you should be thinking at this point in time about this unstable patient with a low GCS and what you'd be doing if you were the paramedic on scene. I think most of us would agree that you'd want to make sure that you had proper management of both the respiratory and cardiovascular status. You'd apply oxygen, make sure they were on the cardiac monitor, and potentially be thinking about putting an IV in and giving the patient a fluid bolus.
All right, and now that leads us to our second poll question.
All right, so on this poll question, have a look and see what you would do in this case. So you should assume the following about patient assessment. So should you treat the patient and not the monitor? Assume that the monitor is right until proven wrong. Assume that the monitor is showing you normal vital signs, or assume that the patient is stable. So again, we'll give you a couple seconds here to answer. Okay, and here are your answers.
Excellent job, guys. It looks like everyone chose what we thought was a correct answer, and well, let's have a discussion about that. Actually, I'm a little bit surprised by the answers that we received, and we'll have a discussion about this adage of treat the patient, not the monitor, and that goes on to the next slide that Christine was going to present.
Okay, so again, we have been seeing some decreased IV cannulation in the field, as well as undertreatment of our patients. Some of the complicating factors that the medics have discussed with us are that they're not seeing visible or not palpating veins in their patient, and therefore unable to achieve or attempt IV access. The blood pressure being reported as normal for the patient, maybe by a healthcare provider or a VON on scene. We're also having medics who are disbelieving the automatic blood pressure reading coming from their cardiac monitor.
I'll interject there, Christine. This is sort of the part of the point of this webinar. One of the learning points that we wanted to make was about this idea of not believing your monitor, not believing the blood pressure reading that you're getting because the cuff is cycling multiple times or for whatever reason. I see a number of audits that come across my desk, and it results in ACEs going out to medics or discussions with medics for that very reason. It seems that we get a number that for some reason we don't believe from the monitor, and then we have what's called diagnostic anchoring, and we're convinced that the monitor is wrong because the patient is kind of looking at you and speaking in full sentences. Now in this situation, the patient also had a GCS of 10, so they had two very abnormal vital signs, a blood pressure of 60 and a GCS of 10. But I think what I would argue, and most of medical counsel or all of medical counsel at SWORB would say, is that treat the patient and the monitor. If the monitor says the patient's sick but the patient looks well, assume the patient is sick and treat them as such until proven otherwise. If the patient looks sick but the monitor says they're well, assume the patient is sick and treat them within your directives, but treat them as if they're sick. If both the monitor and the patient says they're sick, well, that's easy, and vice versa. If both the monitor says the patient's well and the patient looks well, then that's easy as well. But make sure that you include the information that the monitor is giving you. These are very expensive machines, and they've come a long way over the years. And you need to take heed to what the monitor is saying, especially when it's a very abnormal vital sign. At this point in time, if you're not believing the monitor, you could quickly either repeat it or do a manual blood pressure, but for the most part, believe the monitor and move on.
Thank you, Adam. 3 more points or complicating factors that are coming up in our audits are short transport times. Maybe a blood pressure isn't being relayed to the IV certified paramedic. There's also a fear of ruining potential IV sites for the receiving hospital staff. I'm going to ask Adam to just touch on 2 of those points. The first one, the short transport time, and the second, the ruining potential IV sites.
I find the actual potential, I'm going to talk about the potential IV sites first, because I find that the most humorous. Justine has spent a number of years working in Emerge along my side, and we sort of ask the medics to give 2 attempts or at least a couple looks before they decide not to do an IV. But in Emerge, frankly, we end up with 15, 16, 20 stabs in a patient where we really need an IV before we move to a more invasive thing like a central line. So I wouldn't worry about ruining those 2 sites that you're going to try for the hospital staff. I don't think that should be of concern because most patients should have more than 1 potential site. And then there are no visible, no palpable veins. This is where it comes down to knowing the patient's or patient's anatomy. Obviously, there's variability from patient to patient, but most of us have similar anatomy. And in a cardiac arrest situation where you have no flow, or in someone who's significantly hypotensive and likely septic, like the patient we're talking about, or likely septic, like the patient we're talking about here, they're going to have very, very few veins, if any, that you can see or palpate. So you're going to have to go with what you know and know the anatomy, and go for that intern's vein over the thumb or the AC when you know where it is, and essentially move along. So no visible, no palpable veins in a patient that really needs an IV, to me, isn't really an excuse. You should be at least giving it a try.
Thank you. So let's review our intravenous and fluid therapy medical directive. The indications for IV therapy or cannulation are actual or potential need for intravenous medication or fluid therapy. Our conditions for the primary care paramedic, the IV patient needs to be greater than 2 years old or equal to, and the same goes for the fluid bolus. Contraindications are listed in front of you. We're just going to briefly discuss and expand on the indications, the actual or potential need for intravenous medication or fluid therapy.
Well, the provincial MAC couldn't get more nebulous or gray in the recommendations for when to start an IV than they are in this directive. But to me, that represents opportunity for the paramedic working on the street, an opportunity to have multiple or have IV attempts in multiple different types of patients. And if you foresee a need for an IV in the hospital, then I would suggest that you go ahead and give it a try. We want to limit scene time, and it's all a balance between scene time, getting the patient to the hospital quickly, but also doing practicing to your scope and doing the patient the best service possible. I would suggest that, or I believe strongly that medics are a very important part of the healthcare team in Ontario and in many jurisdictions, and it can add a service to the patient simply by starting the IV, so when they arrive at the door of the hospital, it's already there and can be used. Also, that potential need for intravenous is important for that patient that might arrest in front of you, or the patient that might become hypotensive en route to hospital. If you think maybe they're borderline septic or in severe CHF, well, they might not need fluid, they may arrest on the way to the hospital. So there's lots of reasons that I would want to start an IV pre-hospital if I were a paramedic.
Great, thank you. So just to finish off the directive, we're going to consider a maintenance infusion of 15 mils an hour for a pediatric and 30 to 60 for an adult. This leads us to our third poll question. Which of these patients should receive an IV cannulation under your current medical directive? The 65-year-old female weighing approximately 55 kilograms, complaining of weakness times 2 days. Blood pressure is 85/70. The 45-year-old male complaining of a sudden onset of abdo pain with a history of hypertension, and his blood pressure is 170/90. A 4-year-old male complaining of nausea, vomiting, diarrhea times 2 days. The heart rate's 140 and blood pressure is 70 systolic. And your final option there is all of the above. So we'll just wait one moment for everyone to answer. Okay, great. So it looks like most of us are on the right track, that all of these patients in the above situation would qualify for IV cannulation or maintenance infusion under our current medical directive. We will have Dr. Dukelow just briefly discuss each of these patients and maybe the reasons why they would receive IV cannulation either in a TKO rate or a fluid bolus.
Thanks, Christine. I think you've called me Dr. Dukelow more than anybody in the history of any of these webinars. You can start calling me Adam again. Okay. So each of these patients, this is what goes back to that. You know, what's your differential? What are you thinking as you're walking into the room, or you're putting the patient on the stretcher and taking them to the ambulance in order to bring them to the hospital? I'll start with patient C. So this 4-year-old male with gastroenteritis, most likely, with tachycardia and a low blood pressure. Obviously, you should all know our pediatric normal ranges for vital signs. This patient's likely dry simply from too much coming out the top and the bottom and not enough going in. Looking at patient B, the 45-year-old with sudden onset of abdominal pain, this I think would be the most controversial in the medic's mind as to who if they should start an IV or not. You don't have a lot of information here, but if you have a sudden onset of abdominal pain that's severe enough for you to call an ambulance, I would be thinking things along the lines of biliary colic, pancreatitis, renal colic would be the sort of the top 3 on my differential. There's obviously lots of other things. If the person had some sort of disorder like Marfan's or one of the other vascular problems, they could have a AAA, although it would be pretty unusual in a 45-year-old male to have an abdominal aneurysm. Regardless, I think, of the cause of this patient's pain, they don't have any of the vital signs parameters for the fluid therapy directive, but they're likely going to require some IV analgesia. So a PCP, PCP plus IV paramedic would be perfectly justified in getting an IV started in the patient, assuming that this wasn't a really mild pain and you didn't think they were going to need much of anything at the hospital. But if it was a severe pain, which you can define as how the patient looks or what kind of pain scale they give you, I think an IV would be appropriate in this patient. And then looking at the 65-year-old female, obviously as we get older, the very young and the very old, well, this isn't very old, but the older patients can have lots of things that they hide. So weakness 2 days, low blood pressure. In a female this age, I would be thinking probably maybe sepsis with a urine infection that's asymptomatic, or even potentially a silent myocardial infarction or acute coronary syndrome. Again, 2 diseases that require or are going to require intravenous cannulation and therapy at the hospital, so I would fire ahead and get that IV started.
Okay, so to kind of take a couple steps back, what are the facts? Our patients are being undertreated in the field. We have data from April to March of 2011-2012. In the SWORBHP region, we have almost 20,000 documented IV attempts. Our success rate was less than 60%. Which translates to almost 8,000 unsuccessful IV attempts. And as we all know, any break in the skin poses a risk of infection for our patients, and as well, it's possible that our patients are being undertreated in the field and maybe not receiving the fluid they require. So we've examined some of the challenges that paramedics may be facing in the field, and we've come up with these 4. Please feel free to give your feedback if you have anything else to add. The first challenge would be the patient themselves, the setting that paramedics are faced with, ourselves and maybe our attitudes or our confidence levels, and lastly, the equipment that we're provided with by our services. So Justine will start with our discussion surrounding your patient.
So don't you all wish that the veins are this easy to find, but in most patients, but this is quite rare to find veins like this.
I didn't know you were going to throw a picture of Dr. Bradford in there.
Chances are your patients will look more like this lady. So we're going to discuss there are many factors that will affect your techniques in looking for accessing IVs. For example, the sick patient who has veins that are neither palpable or visible, those with frail skin or excess body tissue that limits visibility. We will give some tips on how to increase your chances of finding and feeling and accessing these veins. So the first tip is, you hear people say, oh, I can't see anything. I can't see the vein. So we're going to tell you to feel it. Don't look for it. So I know every instructor has said this and it makes no sense, but this is one time that your eyes can lie to you. It's common to go for the most visible veins, but often these veins are very close to the surface and blow easier. Deeper veins are stronger and less fragile. So palpate your veins with your fingertips and feel around for a springy feeling vein. It will feel vaguely like pressing down on an underinflated balloon, and it will bounce a little under your finger. Avoid mushy or soft feeling veins. These can be more delicate and blow easier. Select the largest vein you can find because they're harder to miss. Once you've found a nice bouncy vein, follow it up a few inches or a few centimeters to make sure that it follows a nice straight line. And check for any hardened areas or sclerotic areas that will prevent your catheter from advancing. So now that you've found that vein, anchor it well. So this is a picture here on the slide of how to appropriately anchor a vein. So you went through all that time to find it. Now anchor it well before you poke. I hear a lot of people always say that the patient has veins that roll. All veins roll, so you have to hold them down so they won't. So gravity is your friend, but poor positioning is not. So hanging the patient's arm down as low as possible to assist with venous filling will help those veins plump up. Raise the stretcher if possible so that you can work at a position that won't hurt your back, so you're bending over. If the site is distal, then try either kneeling or seating yourself down to work closely. If the patient is hypovolemic in shock, you may need to lie them flat. Another technique, if the patient is very hypertensive and the vessels appear to be fragile or tense, you can decrease the chance of blowing the vein or causing a hematoma by using a finger tamponade to tourniquet the vein and or no tourniquet at all. This is sometimes necessary with your elderly frail veins as well. If you attempt to, for the first time, the vein blows immediately, then remove your tourniquet, anchor the vein from rolling with distal and proximal traction and try again. Keeping in mind, though, that you won't get a great flash with no tourniquet. So plan ahead. Your vasculopathic patients, such as diabetics, patients with chronic steroid use, chemotherapy history, a long history of IV drug use, or fragile veins, or used up veins, potentially you want to use a smaller cannula whenever possible to preserve the veins. IV drug users should be encouraged to save a vein for healthcare purposes. I mean, not all of them will comply, but it's worth a chance. So, and also question and believe the patient about their previous IV history as to the success rate. But trust your instincts. They may have never had someone as good as yourself before.
So I told Christine and Justine before we started this that this is kind of like doing a radio show, and it's very uncomfortable the first couple times you do it. And I think the best way to do that is try and answer questions as you go, though. So as if we're taking calls on a radio station. We've had a couple questions come in, and we really appreciate those that are participating both by watching and doing the polls, but also in the chat room. And Stephanie Romano is monitoring that chat room quite closely right now. So the first question was, is the potential for the ER to give drugs enough reason to start an IV? And the short answer is yes. So if you believe that the patient might need antibiotics through an intravenous, or patient might need pain medications through intravenous, then that's a reason to start an IV. Obviously, we can't come down on you or audit you negatively for not starting that intravenous. But I believe that if you believe the patient might need medications, then you can go ahead and make that attempt. So what is this? And the other question, which is very interesting, what is the success rate in the hospital / emerge on the first 2 attempts of starting an IV? And I'm going to go out there without any data to support it to say it's lower than the paramedics, but that's easy for me to say that to this audience, assuming there's no emerge nurses or emerge docs watching. The reality is we don't know what the data is in hospital because it's not monitored near as closely as it is for the paramedics. And the goal of this webinar is not to make medics feel bad or insufficient by the data that we're presenting. It's to make all of us improve and to make all of us a little bit better. So we have medics that are successful 40% of the time and medics that are successful 90% of the time. But I think we can all learn from the tips and tricks that Justine and myself and Christine are giving to you to move that success rate higher, and I think that's in the best interest of our patients. So I don't know if it's better or worse than the local emerge you work near, but let's just all improve our own practice and go from there.
And we also don't deal with the distractions and the other
austere conditions.
Austere conditions that you deal with out in the field. So moving on to smaller is sometimes better. So you may have heard the saying, go big or go home when it comes to IV insertion. But unless immediate massive resuscitation is needed, delivery can be ensured with smaller cannulas with the aid of pressure bags, syringes, stopcocks, or IV pumps. I mean, if they do have those large veins, then go ahead and go big. But most smaller IVs can deliver 1 liter an hour via pump, which equals 24 liters a day, more than most patients will require. So our not so common veins, so we want to consider these when the other veins are used up or not visible. So the veins in your digits, medial wrists, or bacillic veins on the ulnar aspects of the forearms. But be sure that your proposed unusual location, so not armpit, is approved by your local policies and surely needed due to your circumstances.
Let's stay away from breast veins.
So these are some pictures of some of our veins, so it doesn't look like you'll have any trouble finding our veins. However, these are the commonly used veins that all of us have. So if you cannot feel or see the veins, you know your anatomy, therefore you can still attempt your IV insertion, as Adam was saying earlier.
Just a quick question here, Justine.
Mm-hmm.
The question is, when you say smaller cannula, are you referring to 20 or 22 or even smaller than that?
I'm referring to 20 or 22 when I say smaller cannula.
Perfect, thanks.
Yes. So the next tip is make the blood go where you want it to go. So always disinfect the insertion site in the direction of the venous flow. And I didn't do this for many years and was wondering why the vein wouldn't kind of pop up when I was cleaning it. So if you clean towards the flow of the blood, then your vein is more likely to surface. Clean vigorously and widely so that if something else presents itself, another vein presents itself that looks better, then you can poke it instead of having to re-clean the area. And then your tegatum will stick a little bit better anyway. Another question that keeps appearing is knowing when to quit, and sometimes not even trying, but that's not an option, is what we're trying to enforce in this scenario. So knowing when to quit does not mean that you don't try. So not being a quitter is admirable when persistence is necessary to achieve a reasonable goal.
And I think when we talked about these slides and talked about this message, the importance is balancing sort of how long you attempt an IV or how many attempts you make with moving on with the call and your transport times and your scene times. And we're all attempting to minimize scene time no matter what the call and get the patient to the hospital. And so trying IVs en route, although it makes it more difficult, is sometimes a reasonable option. None of us, I think, want to or want you to spend a half an hour on scene just to try and get an IV started. But on the balance, if you take an extra couple minutes, it'd probably be worthwhile.
So when it's time to maybe move on and let somebody else have a turn, it's if you're damaging your patient relationship. Sometimes it's necessary to let somebody else have a turn if you're feeling frustrated and aggravated or feeling unlucky in your efforts, or if the patient cannot tolerate any further efforts. If you're unsuccessful, give a reasonable explanation such as, these things happen sometimes, it's not your fault, it's not my fault, it's just the way it is. Patients with bad veins often know they have bad veins and they've been through it before, so they're a lot more forgiving. Even an explanation of we're not really sure what's happening, and sometimes it comes down to an IV nurse with specialized skills or a physician needing to place a line in a more obscure position or a central line needed. So it's not you, it's the person, it's just the way it is.
So the second factor in our paramedic IV cannulation success rate may be the setting. We are frequently faced with less than ideal settings. That may include areas with poor lighting. So if you are faced with this situation, a good suggestion would be to ask someone to turn on some lights, have someone bring over a big light or move a lamp closer so you can see or at least concentrate more effectively on achieving IV cannulation. Positioning of our patient is always important as well as ourselves. Sometimes we're in cramped areas, so do your best to reposition your patient, maybe reposition the arm, use a less than traditional method of achieving the IV. The setting may include many, like an audience, maybe family members or emergency first responders. that leads us to feeling distressed or less than confident in our abilities. Other distractions, such as the setting itself, maybe a messy situation or could have foul odors. All of these things lead us to possibly...
We can't kid ourselves. I still remember my first call on a ride I did with Tracy Gosling as a medical student in 10 or 15 years ago, whatever it was. And we walked into an apartment with cat and dog feces on the floor and 3 people who'd smoked 3 packs of cigarettes each in the past 20 minutes. I mean, I didn't want to be there for 30 seconds, and Tracy Gosling, obviously, I think whoever knows her knows she's an excellent medic, probably was pregnant at the time and spent, 10 minutes doing the call in the patient's apartment. So I recognize the environment you guys work in and how difficult it can be at times.
Thanks for that, Adam.
Just another actually quick question while we're taking a little bit of an aside. Should lower extremity veins be attempted in an arrest situation, unconscious or via citations?
If you were in an arrested patient, if you're going to the lower extremity, I'd go right to IO. We might answer that question.
Okay, thank you. So in the setting, we understand that it could be less than ideal, and we're going to do our best to decrease any distractions or lighting issues in the area. Back to what Adam was saying about getting an IV en route. If you feel you need to move to the vehicle and attempt the IV en route, that's perfectly acceptable. And when our suggestion is, when dealing with limb in motion or a moving environment, we're going to make sure that we're locking and stabilizing the patient as best we can, so we're safe.
No, this is not the appropriate technique. So it's usually best if the patient is persuaded to completely relax for the venipuncture. Some people will tend to stiffen out of apprehension or the mistaken belief that this will help you. Worse still is when the patient tries to raise their arms that you're confronted with a floating or moving target. So these are 2 examples of how to restrain a cooperative patient. So holding the fingers down so you have access to the hand veins, wrist veins. If you are going for AC upper forearm, then you can tuck their hand underneath your upper arm and have access to that area.
So the next topic we're going to discuss is the medic themselves or ourselves. We're faced with many distractions on the scene. One may being the patient's condition, maybe it's grave, maybe they're very sick. Would have people standing around, we feel rushed, we want to get off the scene. But what we'd like to focus on here is that you be patient. Stop and focus on your task at hand. Consider delegating some tasks to your partner, suggesting maybe if you have fire on scene that they're preparing the stretcher and getting ready to go so you're not faced with those distractions. Also, again, focus on your task at hand, worry about your other tasks later, and be confident. Focus.
So those are what Christine has just discussed. So now moving on to the equipment.
Okay, so this is a bit of a touchy topic. Services, base hospital does not choose the equipment that's put into your ambulances. That's through your service. So sometimes you're faced with getting new equipment. So we suggest that you look at it, practice, and ask questions of your service operators if you have any. Commonly, there's videos that accompany your new equipment, and we suggest that having the right attitude towards new equipment may help you with your success rates.
And whenever seek assistance from a more experienced person and or your educator.
On that note, I think we will discuss 3 of the most typical types of IV catheters within our region.
So we're looking at the Nexiva, the Autoguard, and the Introcan. So this is the BD Nexiva. So there's some little techniques with this system that have to be in place in order to have a successful IV start. So you start by breaking the seal between the catheter and the needle, separating the white and the gray sections. And we have a little video following these tips just to show you an example of this. So keep the stabilization platform grips pushed together. So upon insertion, look for initial blood return in the catheter near the insertion site. Then lower and slightly advance the entire system about 1/8 of an inch to ensure the catheter tip is in the vein. So it sounds weird, but you're going to advance the needle and the catheter together an extra 1/8 of an inch post blood return. And then you're going to look for continuous blood return up the extension tubing. For a smooth catheter advancement, push the catheter forward off of the needle, a term called hooding, where the needle comes back into the catheter so that it's not exposing the vein to the needle anymore. And then you're advancing the entire system into the vein. When you're pulling out, you're shielding for shield removal, then you're pushing down gently on the stabilization platform, and you're gripping the white part and pulling it directly back. Keeping in mind you need to keep the angle low and directly against the skin so that you do not shear the catheter. If you pull it up, then you're going to possibly shear the catheter. So this picture just shows you what blood return looks like if you have a really nice juicy vein. Keep your catheter, your clamp, open upon insertion. Once your blood return comes back, then apply the clamp and then remove the hub at the end to put on your IV. So hopefully this will work for us. This is our video on BD Nexiva. So this is a big BD Nexiva that many services use, and we'll be demonstrating on this today. So what I want you to start with is preparing your catheter. The first thing you need to do is open your package and get it ready. So you start by hooding your needle to release the seal on the top. So you do this by pulling slightly back on the end of the catheter, and that breaks the seal at the tip of the needle there. Then you have to make sure that it's back in place and in working order so that you have your needle above the tip of your catheter. So then we need to prepare your site and get ready for that. So apply your tourniquet as necessary with as much tension as appropriate. And look for your vessel. So as you can see here, you can't see the vessel, so we're going to rely on our fingers to help us walk us through this process. So I know that there is some veins up in this area, some AC veins, so I'm going to palpate around to see if I can find one. And there's a nice juicy one right here. I can't see it, but I can feel it. So I'm going to prepare my site by working towards the flow and cleaning the area so that my tegaderm will stick accordingly. Then I have my Nexiva, and I'm going to pull the catheter up around my hand so it's not dangling in my way. And there we go. Making sure I have my tegaderm ready to go after I pull. So again, I feel my site. I wipe it down. And I'm going to apply traction above and below my site, and I'm going to poke right there where I know what my vein is. So a little bit of angle in. Once I have my flashback, I'm going to drop to the skin and go in just 1/8 of an inch further. Then I'm going to advance my catheter slightly, put my needle back, and as you can see, it's coming out the side. And I'm going to push in until it's prepared. My site is prepared. Then I need to grab onto my stabilization, grab onto the end of my needle, and pull out. Discard my sharp. So that's one example on some of the techniques you can use for using the Nexiva. So next we're going to move on to the BD Insyte Autoguard. So there's a few different techniques using the Autoguard. Start again with breaking the seal between the catheter and needle. This is done by rotating the barrel 360 degrees. And again, there's another video to demonstrate this. Following this, make sure the catheter is seated back in the notch so that you have your needle advanced beyond your catheter. Upon insertion, trust your instincts and take a pause and look for the flash in the catheter. After you see the flash, lower the angle and advance 1/8 of an inch, similar to the Nexiva. Then hood the needle while pushing the catheter over the tip while maintaining traction on the skin. Make sure you have that good anchoring. And then advance the entire system. Once it's in place, press the white activation button, making sure that you don't have any angle on that needle when you're pressing the button, because again, that can shear your catheter. To minimize your blood exposure, make sure you have that digital pressure beyond the catheter tip. And again, here we go with the video. Now we'll be inserting the Insyte Autoguard from BD, and there's a few different tips for this one. So when we release the seal, we need to turn the catheter in the 360 around the needle in order to release the seal at the top of the catheter. When I mention hooding, what that means is you're pulling the catheter tip over top of the needle as you're inserting, as to not puncture the vessel with the needle. And then we will be releasing the Autoguard from there, not to spray blood on everyone. So that's that technique. You have to make sure your catheter sits right back in the bevel there before insertion. Then we'll find our site. And this time we'll do a hand. We'll be lucky enough to see our vessel this time. Again, cleaning widely and vigorously. This helps with sensory deprivation, as well as having the vessel come up. So inserting again close to insertion site, close to the skin. So we'll go in and look for our flash. And again, advancing slightly and hooding our needle and advancing the rest of the way. So from there, applying pressure above the site so the blood doesn't come out, and then releasing our needle. And we'll hook up to our intravenous. And apply our tincture. So we'll secure our site. So please disregard the Tegaderm application. It was not ideal, but it's just a demo. So now we're going to talk just slightly about the Braun Introcan. And this insertion technique is very similar to the Autoguard, minus the large chamber in the back. So the important difference between the Braun Introcan is do not rotate the catheter prior to insertion. So breaking the seal is just slightly putting the needle and putting it back. It's important to break your seal before you insert, or you're advancing. When you go to advance the catheter, you're not going to be able to pull the needle out of the catheter. So you will end up either shearing the catheter or shearing your vessel. So it's really important to break your seal before you insert.
Before we move on, Justine, I'm actually going to punt this question over to you. There's a question that came up on the chat room that says, I'm finding it very difficult to palpate the veins with our gloves on. Any suggestions on how to improve this?
It takes practice. That's what it comes down to. You don't want to risk exposing yourself at all, and that includes pulling your finger, one finger out of your glove, because I see many people do that. All in all, it's a skill. Just like learning how to start IVs, learning how to start IVs is an additional skill with your gloves on. So just keep practicing and do your best. If you want to, feel for the vein. If you're not going to be exposed to anything, feel for the vein first and mark it with your fingernail, then wash your hands, apply your gloves, and then go for your poke. That's another option as well, but just don't start the line without your gloves on.
I think the only thing I would add to that is to have, if you can, well-fitting gloves. So if your hands are big enough for the smallest gloves, make sure they're nice and taut on your fingers.
And as you can see, that's not really an option for me, so you got to sometimes just deal with that as well. So now we're moving on to CVADs, your central venous access devices. So I would like to just thank Janet Barr, the peripheral central venous consultant at LHSC, for helping us put this information together. So what is a central venous access device? Basically, it's a hollow catheter, a flexible tube inserted into a large vein of the body. And that vein, the recommended site is your superior vena cava, your SVC. So in this picture here, the arrow is pointing to the tip of the catheter, but the catheter leads outside of the body to where you can access it, or internally, like in a portacat. So your PICC lines are the most common. So they're usually recommended for IV therapy of 7 to 14 days, but can remain situated for weeks to months, usually located in the upper arm in your large AC veins there. They're often easier to insert. Sometimes they can even be inserted at the bedside. They're flexible with movement, but there is no built-in stabilization, so they can migrate out on their own. So if you come upon one that's migrated out, please don't access it. The other thing to keep in mind is if you're starting an IV lower than your PICC line is do not put a tourniquet around the PICC line, and it's recommended you don't do blood pressures if at all possible over that line. So our tunneled catheters, often referred to as your Broviacs or Hickman. Your Broviac is usually a single lumen, and Hickman can be a single to a triple lumen, and inserted anywhere in the upper chest region. Usually reserved for long-term use, continual IV infusion, such as TPN or chemotherapy, or someone who needs frequent blood draws. These do have what's called a Dacron cuff that's inserted, it's blown up once it's inserted under the skin. That helps with stabilization and helps to decrease infection risks. So our next one is your implanted ports. So they're called portacats, and they're recommended for continual or intermittent long-term IV therapy. There are no external parts unless you have it has been accessed. So you will probably not be accessing these ports because you do not have the equipment to access it. They need a special Huber needle. It's a non-core needle for access. So if you see it, then you're just going to note that it is there. And then we have our non-tunneling short-term central catheters, subclavian, jugular, femoral, or UVC, which is your umbilical. They're often stiffer and having potential for vessel damage. They can be multiple lumen and or single lumen, and they're difficult to secure, easy to dislodge. Most of the time they're placed within the hospital and removed prior to discharge, so you may not see many of these, but people are also at increased risk for DVT, so if they have recently had one, that could be part of your differential. So flushing your central venous catheters.
I think it's a good time to sort of interject here about central venous catheters, and the ladies are going to go over some of the myths about them and about what people think or why they're afraid of them. But I want to emphasize that you don't need to be afraid of them. Essentially, they're a big IV, and we don't want to use them willy-nilly because when we use them, we increase the rate of infection, and they may need to be replaced. But the long and short of it is if the patient's dying in front of you, they're not going to be worried about their central venous catheter needing to be replaced when they're waking up in the ICU 2 days later, and nor should you. So if the patient's dead or meets your directive, then we're going to show you how to do this properly. I know it doesn't happen very often, but it's just a big IV going into a bigger vein that lasts longer and is less likely to get infected. And so you need to treat it that way and go through the process that Justine and Christine are going to review.
And so I guess just to follow up on that, Adam, we do have another question. If it does have multiple ports and the ports are different colors, does that matter? Can we use any of them?
I believe later in the presentation, Justine's going to review that. But essentially, the ports are different lengths and different sizes, but they all go into the same vein.
Exactly. So that's all I was basically going to say in the presentation. So good. Thanks, Adam, for covering that. So with flushing your central venous catheter, it's a required ACP skill set. So if you're not comfortable, again, you can practice, get more comfortable. If you see it and you need to use it, then by all means use it. So always flush the lines with a turbulent push-stop motion. And that's an on-off, and we have a little video to show you how that will work. Only use 10 cc syringes or larger. This is a little window that shows you PSI is what it is, and that's pounds per square inch. So the smaller the catheter you use, the larger amount of pressure that's going into that line, which increases your risk of blowing the line. So you want to use a larger 10 cc or 20 cc syringe. So starting with accessing it. So you want to clean the access device first, so with some alcohol swab, run it over it, attach a 10 cc syringe that doesn't have anything in it, withdraw for blood return. If you don't get any blood return, then attempt to flush the line with normal saline. If you can flush it easy, then go ahead and access it, use it, attach your IV catheter. If you get blood return, even better, you want to withdraw 3 to 5 cc's and then attach your normal saline and flush and hook up your line, and you're ready to go. If the catheter appears like it's not in place, like that PICC line is out, doesn't look right, if you don't get good blood return or the catheter doesn't flush easily, if it's red or swollen or there's any signs of infection, then don't use it. And if you are trying to flush it and it's not flushing, never force flush, because then you risk blowing the line. So here is our short little video, and it's a simulated video, so keep that in mind.
This is a demonstration on how to access a central venous catheter. This is a simulated PICC line that we have set up for you today. So we're going to start with cleaning it. So getting your alcohol swab, cleaning the site for approximately 15 seconds if possible. Then you're going to unclamp. You're going to take a 10 cc syringe that's empty. You're going to hook it up to the end, and you're going to attempt to draw back 3 to 5 cc's of blood to confirm placement. Unhook, attach your 10 cc syringe with normal saline, and you're going to flush using a push-stop technique. So push-stop, turbulent, all 10 cc's, and then you're going to hook up your line, and it's ready for use. So this is a demonstration.
Great. So that was Christine there, her blood in the video. So we all know that she drinks a lot of coffee, so that's why her blood looks that way.
Thanks, Justine.
Okay.
Now we're going to quickly review the Central Venous Access Device Access Medical Directive and recall that this is for advanced care paramedics. The indications for its access are the actual or potential need for intravenous medication or fluid therapy when IV access is unobtainable, and as Adam stated before, your patient is in cardiac arrest or a near arrest state. This leads us directly to our poll question number 4. So, who can access a when should a central venous access device be accessed? When a patient presents hypotensive and has one, when a patient is in a pre-arrest state and IV access is unobtainable, in a cardiac arrest, or when a patient is hypoglycemic and seizing. So you can enter your answers now. Okay, so this one was a bit tricky, and it looks like we've successfully answered it. The correct answer is B, in a pre-arrest state and when IV access is unobtainable. Answer C is not correct because we will not be accessing a central venous device in every cardiac arrest, and we're only going to do so if IV access is unobtainable. Good.
So now we would like to offer
There's one more question that's come up in the chat room that I'll address, and then while I'm doing that, maybe think about it if there's any questions that you want to put your hand up to ask verbally, or other questions you want to put through the chat room. So the question is about a combined PCP crew. So 2 PCP medics, where one is IV certified and the other is not IV certified. And in what scenario should the IV certified medic take over the call? So the example is given in a CTAS 3 or 4 patient with a potential need for medication, such as a renal colic patient, or if fluid is necessary. So there's no black and white answer to this question, unfortunately. We'd all love if everything in medicine was black and white, but there is not a black and white answer to this question. And you'll have to leave it to the specific call. If you're not going to do anything with that IV, and you don't think the patient's going to become unstable or have a cardiac arrest, then I would suggest that you can leave it as is. If there is a need for fluid and the patient might be septic or dehydrated or all the above, then it would be very reasonable for the IV certified medic to take over for the PCP non-IV certified medic. So we're not seeing any more questions coming up at this point in time. Oh, there is a question about, so if a portacath has an access hub in situ, can it be used for a critical patient? So I'm assuming that the medic that's asking this is showing up on scene, and CCAC is already there accessing the hub that's in place. And I would, off the cuff, I would say yes, if it's already in place and the nurses access it, you can use it like an existing IV line. Looking to see if any more questions come up in the chat room or any hands are put up.
We did have a tip from a seasoned medic that did come through. When there was a question about practicing palpating veins, and Justine's answer was simply practice. One of the medics suggested going down a glove size, so a tighter glove might be able to help you palpate those veins. So just a suggestion.
And just make sure you cut your fingernails before so you don't cut the glove. So another medic has asked about withdrawing blood from an IV before flushing, or from a central access device before flushing it, if it's heparin. And yes, in some scenarios, or most scenarios, a central venous access device and even peripheral IVs that are in place in the community have a small amount of heparin inside of them. All right, if Gravol is only given for nausea, can a non-IV certified PCP monitor the patient en route to hospital? In general, once a medical directive has been undertaken by a medic that is certified in that medical directive, that medic should assume care of the patient until transfer of care at the hospital. So the IV certified medic that's given the Gravol and presumably started the IV should presume care of that patient until transfer. That's all the questions that we have. You'll see the references on the screen. I want to thank Christine and Justine for their preparation for this presentation, and thank the audience for putting up with that the 20-minute delay we had at the beginning of the presentation due to broadband internet difficulties here at the SWORB office, and thanks, Stephanie, for your support.
And just a heads up for those of you who might be interested, we do have another webinar tomorrow on DNR issues at 1 p.m., so feel free to join us for that. Thanks, everyone. Have a great day.